the urine tract, of the colon, of the blood, of the nerve. So that means the cryosurgery is much safer than microwave and radiofrequencies in the pancreatic cancer. Pancreas, the same. Pancreas also have the pancreas duct, the duodenal, the gastric, the bile duct. All is sensitive to the radiofrequencies. But cryosurgery maybe is safer, is a choice. So, what's the advantage of the cryoablation? What's the disadvantage of the cryo? So, the difficult thing, it is inside in the body, not easy to position, to control the ablation area. How to do it? We do it in the open surgery, but many of the patients come here after surgery and the patient condition is weak, will not accept. So we in the world first report the percutaneous cryoablation for pancreatic cancer. How will you do it? From which way? Transabdominal, through the gastric, or through transdural approach. This is the way we do it. Transgastric approach. Puncture through gastric, then decide directly inside. This is the safe way. But not through the colon, not through the intestine, just gastric. Also through gastric, you can see the needle, the ice ball formed clearly. When you monitor, the ice ball near the gastric stop freezing. Some we can, in the head of the pancreas, you can puncture through the liver. This is the tumor here, through the liver, not through the. And some you can directly, with the probe, ultrasound probe, you press down and push away of the gastric and the colon directly inside the tumor. It's much safer. This is another way. This kidney, this colon, through this way inside the tail of this tumor. You can see the needle, the ice ball form, freezing the tumor. For the tail of the pancreas tumor, from the back, puncture is much safer. You can freeze it more. Also, and ultrasonic guided. When you puncture, you can in real time. When you puncture, you can see the needle inside, not puncture inside the vascular, the bile duct. This will decrease the risk of fistula or bleeding. So important is do something and you monitor. So this is one of the patient tumor, needle freezing, 1.5 months, contrast CT necrosis. So we have published a paper in magazine to show which way in different situations for the percutaneous cryoablation. We also do some animal experimental tests to show. Do not like the liver and the lung, the freezing time and the ice balls margin not need too much. Like in the liver, you need 1 centimeter bigger than the tumor. But in the pancreas, the ice ball just 5 millimeter bigger than the lesion can cause the complete necrosis. Why? Maybe some different reasons, such as the pancreas itself have some digestive enzyme or some working. I'm not be sure, but result to pancreas cryoablation no need too much of freezing time or energy. Just short time and low energy is enough. Cause a complete necrosis. side effect, in the beginning we worry about a lot of the side effect, but gradually the side effect in our experience is less than what you think or care worry about. No death-related complication. Important things you worry about the pancreas physical, pancreatic. Important things you must puncture precisely, not the needle puncture inside the bile duct, the pancreatic duct, not in the vascular. That means such complication will not too much. So that means you must target the tumor. And also we know, because some important structure, we cannot freezing too much in the head of the pancreas. But in the tail of the pancreas, you can freeze a big ice ball, you can completely freeze the tumor. But in the head of the pancreas, we cannot freeze too much. So that means you cannot radically ablation of the tumor. We combined with some other treatment, such as using 1 to 5 seed implantation combined with our, we published a paper to show it's much better result for the head, the tumor in the head. Also, we compare with the freezing and combine with seed implantation and the seed implantation, just only seed implantation. Cryo combined therapy is a much better result. We combine with immunotherapy, result is better. Also, we do the pain control, can relieve the pain immediately after the freezing. Some of our case report, this is the tumor after freezing, 3 months necrosis in the head. Before it's active, PET-CT. Also the tumor in the head, freezing with combined with the using seed complication is another. So you mean just after freezing, this is the freezing area clearly. Inside is the using seed. Also such like a situation before, after the PET-CT not active. This is before, after PET-CT scan is negative. Is negative. So summary from our clinical experience to show cryosurgery is a choice for the patient not suitable for surgery, and can combine with the UVC, combine with immunotherapy, can prolong the patient's life. But today I want to introduce another technique for IRE, nano knife. This is a nano knife just approved by the US FDA in 2 years ago. So what's this? What's this machine? What it can do something for the patient for pancreatic cancer? I just want to show a case. This is Professor Feng from Sloan Kettering. He showed me, his lecture showed me a case. This patient is his colleague. You see the colon cancer metastasis in liver. The tumor is so big, the patient refused chemo, nothing to do, just do the nano knife, IRE for this patient. They do it for it. This result 2 years later, the tumor like this. So I'm so impressed for this patient. No chemo, just do IRE from Sloan Kettering. The doctor suffer from the colon cancer. So it impresses you so much in such important area. IRE can do and see. So why this happens? That area we cannot do radio frequencies, we cannot do too much of cryo, but RE is working because you see this is the animal experiment. The RE it will repair completely, nearly completely, not damage the structure of the vessel of the bile duct. This compared with the radio frequencies. This tumor with radio frequencies, always there. This tumor with the RE, after freezing, after RE tumor, it is absorbed, not like the radio frequencies, cannot repair completely by the tissue itself. So this I will show its difference. This is a tumor here. This is near the duodenal intestine and go. This area they do like this after tumor necrosis. So all this show the RE can do something the thermal ablation cannot do in the important area.
Professor Niu, 1 minute please.
Okay. So we also do some animal experiment to show it's safe. We published the paper in magazine near the such as the bile duct. Also in pancreas, also it's safe. This is a patient with doing the RE mid pancreas, puncture inside. Patient recover quickly. Second day, the patient can work. So not so much situation. So I just show this is some I visit the US. Some picture for the other doctor. After freezing, it is low density, big, and also this is for the RE for the pancreas. They do. This is a tumor. This is a needle. They put small needle for this RE after necrosis. Also, this is a needle for the pancreas after the recovery. So this I visited the patient, I visited the hospital in Danforth, Sweden hospital. The professor, the tumor in the liver, but he do RE first. He want to do R0 resection, then they cut. So I think for pancreas, this is a professor from California. He told me, any pancreas cancer, he want to do RE first and then cut, because this can guarantee the R0 resection. This I visit, I will professor from other university, visit Miami University. This will publish the book for RE. Thanks so much.